Hello everybody, so I'm Belinda Lennox, I'm a psychiatrist and I'm co-supervising this project with Apostolos Tsiakristas, who's a health economist. We're both in Oxford and we're really delighted to have recruited Ed, who's a superstar economist. We persuaded him to come from a proper job to come and be a PhD student with us for the next few years, and he's going to tell you about our project.
Thank you. Okay, Ed, please.
Great, thank you, Belinda. So the topic of my PhD on the website is an economic model of psychosis using actual treatments and health outcomes. So I'm in my first year of PhD in psychiatry at the University of Oxford, but as Belinda mentioned, my background is actually in economics and policy. So my supervisors, Belinda and then Apostolos, are experts in psychiatry and health economics respectively, and my research sits in between those two disciplines by applying economic methods to improving mental health services. So before I get onto the economics, I'll just quickly recap what EIP is, early intervention in psychosis. So we've heard from a couple of other presentations what psychosis is, but EIP is an intensive package of care aimed at minimizing the duration of untreated psychosis and improving the long-term trajectory of the illness. So the main components of EIP are case management, so a care coordinator who's responsible for the day-to-day case management of a small number of service users, usually about 7 or 8. Antipsychotic medication, including clozapine after 2 unsuccessful trials, CBT for psychosis and family intervention. So these are 2 forms of psychological therapy, carer-focused intervention and support, physical health assessments for things like smoking, alcohol, cardiovascular disease risk, diabetes, things like that, and individual placement and support, which is a program for supporting people with psychosis back into employment education. So EIP has been shown to be effective in randomized trials. We've got some results from a meta-analysis there. It increases the likelihood of recovery, reduces disengagement from services, reduces time spent in inpatient settings, and improves general functioning. In 2016, the access and waiting time standard for EIP was rolled out, making it the expectation that this will be the standard of care for people experiencing a first episode of psychosis in England and Wales. And there's been real-world evidence since then showing that it's more effective than the models of care it replaced. So why am I doing any research on this at all then? Well, firstly, there's a very strict time limit on how long someone can spend in EIP care of 3 years, even if someone could benefit for longer. And that's the topic of an NIHR-funded project on extending the duration of EIP, which is where a lot of data for this research comes from, and which Belinda and Apo and I have worked on previously. And the second thing is funding for EIP services. So the recommended budget for an EIP team when it was established in 2016 was £8,250 per person on their caseload. In 2021, the national average spend was around £7,000. That's not adjusting for inflation, which did occur between 2016 and 2021, and has occurred even more since. Some teams reported spending less than half of the 2016 recommended amount. And this is a big part of why a lot of people do not receive the recommended treatments for which they're eligible. So, for example, 46% of eligible individuals in 2021 received CBT for psychosis, and just 21% received family intervention. So the purpose of this research is to work out what EIP teams with constrained budgets should do, and what it means for service users that parts of EIP are not currently provided due to limited funding. To do that, we're not going to do a trial or anything. We're going to pull together a model, so a simulated model of EIP provision and outcomes that can be used to improve services that people with psychosis receive. So this will include understanding individual variation in the EIP components received in practice and what the expected effects of those EIP components on key outcomes are, estimating the drivers and rates of engagement with different components of EIP care in practice, using those that information to build a discrete event simulation model of what happens to an individual over their lifetime after they've been accepted onto an EIP caseload, and then using that model to test different combinations of EIP provision within a fixed budget to optimize EIP care. So the Extend study, which I mentioned earlier, will provide a linked real-world data set on EIP provision and outcomes, including hospital data, mental health data, mortality. And it's also providing access to a really fantastic group of service users and carers who will be consulted throughout the model development process and the DPhil. So I think that I'm over time already, but just to quickly say thank you to an enormous number of people from mostly covered by the Extend project, also people providing the data, providing access to the data, and of course, my supervisors.